Dr. Baill earned her medical degree from the University of Medicine and Dentistry of New Jersey. She did her residency in gynecology and obstetrics at Johns Hopkins Medical Center in Baltimore. She then worked 3 years in the U.S. Public Health Service, achieving the rank of Lieutenant Commander. In 1990, she received the Public Health Service Achievement Medal. She is a board certified in obstetrics and gynecology. She is a fellow of the American College of Obstetricians and Gynecologists and is a certified menopause practitioner by the North American Menopause Society.
Impressive.
It is very impressive.
I don't have an MBE. Give it time.
Give it time. That's right. During her medical career of over 30 years, she served on the National Medical Committee of Planned Parenthood and as a regional and local medical director. She is currently an advisor, laboratory director, Florida State House Physician Liaison for Planned Parenthood of Southwest and Central Florida. Dr. Baill is the founder of the Menopause Center in Orlando, where she served as medical director for 12 years. She's been affiliated with the U.S. College of Medicine since its founding, having served as a curriculum advisor and admissions interviewer. She formally joined the faculty in 2015 and is now a professor of obstetrics and gynecology at UCF. She's also the author of a children's book, Why is Mommy Crying? Explaining Early Pregnancy Loss to Young Children. This was released in 2021. The book is available as a paperback and on Kindle. So please welcome Dr. Cori Baill.
I think, yeah. I have a pretty, you can put it on here, but okay. I don't mind if it's on, but I can't like walk and talk, chew gum. All right. So thank you all for having me. And Jocelyn, thank you so much for making this very easy for me. What an incredibly organized person you have. Every organization needs somebody like Jocelyn. Yeah. And she made this very easy for me. And as many of you probably know, I'm also a good friend of Judy Siegel. So it was a very nice connection. It's a small world, right? I'm not sure what scientific skeptics are. I really hope that my lecture will be scientifically based. Sometimes I would tell patients, I feel like the world of menopause is sort of like the wild west, and I'm the sheriff in town, So hopefully I can give you some scientific underpinnings to understand some of the issues around menopausal health care. The slides that are here, and thank your AV person whose name I'm sorry I didn't, David, I didn't catch. Thank you. He got them so that you can at least see some of the slides. These are all pictures I took from a recent trip in Tanzania, just so that if you really aren't all that interested in menopause, there'll be something interesting to look at. All right, so on we go to talking about reproductive aging. I don't know if you realize that you're born with all the eggs that you're ever going to have. And that's actually several million follicles at birth. But by the time that you've entered puberty and you are starting to have regular menstrual cycles, which recruit about 1,000 follicles per cycle, you really only have about 400,000 follicles left, less than 500,000. And then at menopause, there's less than 1,000. And it's just an amazing process. Because even if one ovary is removed surgically, that rate of loss adjusts so that you still hit menopause at the same age. It's been an amazing biological constant, not really changing since described by Galen in ancient times. It's 51.8 years of age with standard deviations between 45 and 55. There's a couple of things you can do to make menopause come a little earlier, such as being a chronic smoker or living at a very high altitude, but we're talking about shifting this a matter of months. There are also genetic clusters. It tends to be familial, so that a whole family maybe has menopause a little earlier or a little later. But this age has been an amazing biological constant that hasn't changed. We've seen the age of menarche, or the first menstrual cycle, drop down as we have more estrogen-like particles in our environment, and really primarily through better nutrition. But that has not changed the age of menopause. So I think that's very interesting. I think menopause is very interesting. this looks like a very busy slide, but the main point I want to make is that, pardon? Oh, yeah. So if this is your normal menstrual cycle with its normal ebbs and flow every month, this represents 6 months of cycles. Up, down, start, stop, have periods, but it has a nice pattern to it, right? Predictable pattern. The SWAN study, which is the study of women across the nation, managed to talk a very large number of women, over 3,000 women, 42 to 52 years of age, into collecting their urine and bringing it into the study centers every week and being able to, an amazing group of researchers. They're still generating data from the SWAN study. From 1994 to present, they are still generating data. They managed to talk women to bringing their urine in, and then they could capture what happens in the 6 months to hormones prior to menopause. It is not a gradual decrease. It is a rock and rolling coaster, and you have giant peaks and valleys, and you're going to have things like, because of these big fluctuations, you're going to have irregular bleeding and variable cycle length, and we're going to talk about some of the hormonally sensitive issues that occur in this perimenopausal period, which is just can be so chaotic hormonally. And then, of course, postmenopausally, everything levels out. And that top red line is the FSH, which is something that's sometimes measured, but really menopause is a retrospective diagnosis. So there is this progression of symptoms. And early on, you have vasomotor symptoms. That's VSM, hot flashes and night sweats. And these can occur, these can start years before the final menstrual period. You'll see changes in the menstrual pattern, as you can understand now from seeing those big fluctuations in the hormones. You can have exacerbation of those hormonally sensitive symptoms. And by that, I mean things like people who get a migraine before their period. You're going to have, often I would see patients come into the menopause center complaining of worsening migraines, worsening premenstrual symptoms, worsening of if they have any other health issues like being prone to depression or OCD, the affective disorders, that these worsen also because estrogen supports those neurotransmitters that even out mood. And when you have these big fluctuations, then of course that makes those affective disorders more challenging. Cognitive effects, specifically name recall, word recognition is often a complaint. Breast tenderness, you have higher levels of estrogen in some cycles than you've seen since puberty. The brain is busy trying to tell those ovaries to please roll over and do it again. And then when the signal finally catches, you're flooded with so much hormone that you have new breast tenderness. Similar to like in pregnancy, acne can occur. People at 45, why do I have acne again? You can see because as estrogen levels drop, androgens, which we all make from our adrenal glands, even though we're women, we do make some testosterone. Those androgen levels assert themselves, and you see hair thinning at the part line initially, and bone thinning with the withdrawal of estrogen. Just a whiff of estrogen holds the bones together, but without it, you can see rapid bone loss. So later on, as menopause progresses, we see genitourinary symptoms, which is also called atrophic changes, and that's vaginal dryness. Often there's a decreased susceptibility to vaginitis, to things like candida, because of the lack of moisture. But that also means you can see increase in urinary tract infections from ruffling up the urethra, which runs along the top of the vagina, and there's no longer the same support without the estrogen. Mild incontinence can occur, again, because of that impact on the urethra, and of course, painful intimacy. As menopause progresses, those genital urinary symptoms can progress. And you also see more of a male pattern hair loss. So instead of just being at the part line, you're starting to see it at the temples, again, because of androgen remaining while estrogen is withdrawn. And the late consequences of bone thinning is osteoporosis. And we're going to talk about all these in more detail, but I wanted to give this overview of the kinds of symptoms that are commonly associated with menopause. Sounds familiar, ladies, right? And much of what I'm discussing comes from the hormone therapy position statement from the North American Menopause Society, which I think is now renamed the Menopause Society. And I want you to know that the information I'm trying to impart to you, I think is scientifically based, which is how I want my medical care.
Yes.
Unlike what's coming down the pike here. I want to talk about the definition of adverse effects, because I think many women are very frightened by what happened with the results of the Women's Health Initiative and being very frightened of side effects from hormonal therapy. A very common side effect would occur 1 in 10 or less frequently. Common side effects are between 10 and 100. Uncommon is between 100 and 1,000. Rare is anything that occurs more than 1 in 1,000 and less than 1 in 10,000. All right, so that's rare. And very rare is greater than 1 in 10,000. All right, so that's the definition of when we talk about things, side effects occurring: rare, very rare, uncommon, common, and very common. So this is a slide showing the results of the Women's Health Initiative. Now, this part of the Women's Health Initiative trial, the estrogen-only part, was not reported. The only, initially, it was reported several years later, but by then, this is the part that really got the news, that it actually, in a real departure from what's how medicine, how study results are usually reported, instead of being reported in the literature, in the scientific literature, they held a press conference. And they said that using Premarin and Provera, which at that time, Prempro was the most commonly prescribed hormonal therapy for women with a uterus, you were going to see an increase in deep vein thrombosis and pulmonary embolism, which was expected with oral therapy with hormone replacement. But the surprise was the increase in coronary heart disease, stroke, a small increase in breast cancer, colorectal, and breast cancer. None of these, this red line is that rare line. None of these exceeded what we would call a rare side effect, greater than 1 per 10,000 per woman years. And we also saw a decrease in colorectal cancer, all cancers, certainly in fractures, because remember, just any estrogen at all is going to keep the bones together. There was also a decrease in what we call all-cause mortality, or death for any reason, was less in the hormonal therapy group, as was diabetes. Now, these results were only for the women who I think were 49 to 50. Let's see, do I have it on the slide?
50 to 59.
Thank you, 50 to 59. Yeah, 50 to 59 years of age. Now, the Women's Health Initiative study intentionally looked at women who were older than 59 years of age. There was a 60 to 69, and then the even older than that group. But this is just the younger group. But remember, to be a part of the Women's Health Initiative study, they actively discouraged anybody who was having active menopausal symptoms, because you had a chance of being randomized for 8 years into no treatment. So these may not really represent every woman, and it only used this one progestin, this medroxyprogesterone acetate, which has its own problem, and this only used this one dose. Now, even despite these limitations, a couple of years later, when they released because this part of the study ended early because of these increases in breast cancer, stroke, and coronary artery disease. When they did release the findings of the WHI for the estrogen-only group, the Premarin-only group, they saw what they had expected really in both arms, which was the oral therapy had a small, rare events of deep vein thrombosis and pulmonary embolism, but all the others were improved, less cases. But unfortunately, the damage was done. This was reported as a relative risk. The news conference sensationalized it. It was sensationalized in the press. 26% increase in breast cancer, 29% increase in heart attacks. Despite these small numbers, the actual numbers were 8 per 10,000 women per year. These were the actual risks. So, let's see here. Okay. having trouble reading what's on the slide in front of me. But so I think I've covered most of this with you, but the damage was done. More than half of the women in the United States stopped their hormonal therapy overnight. Many resumed at a lower dose, which I think is appropriate. But overall, hormonal therapy prescriptions decreased 80 to 90%. Wyeth, the company that made Premarin, bankrupted, went out of business, despite the fact that there were no adverse events in almost 98% of the women in the study. So this is the context for which I'm trying to explain hormonal therapy to you. There are many formulations of estrogen available. Preparations include the equine estrogen, the horse-derived estrogen, or Premarin, pregnant mare urine, Premarin. That's where that name comes from. But there's also micronized estradiol, which is the main component you see in most oral contraceptives, and ethinyl estradiol. There is just regular old estrogen around, the same thing that your ovaries made. It is identical to what your ovaries made. It's a predominant estrogen of your reproductive years. Now, as you get older, it's a different estrogen that predominates. It's a much weaker estrogen, but this estrogen, estradiol, is the estrogen. 17-beta estradiol is the estrogen that your ovaries make and is therefore bioidentical, though that term is not typically used for prescription medications. It's used as a marketing term for compounded hormonal therapy, which we will discuss, I promise you. Now, the progesterone that was used in the Women's Health Initiative with medroxyprogesterone acetate, a synthetic progestin with a lot of androgen effects. And remember, men have heart attack 10 years younger than 10 years younger than women as a population group. Have more adverse lipid effects because of their androgens. Many people think that the problems with the Women's Health Initiative could be laid at the door of medroxyprogesterone acetate. Remember, the estrogen-only arm did not have some of those problems. Micronized progesterone is structurally identical to the progesterone produced by the ovary, and it is now available commercially. One thing, though, about micronized progesterone is that it's sedating. I don't know if any of you ladies have been pregnant, and you get up in the morning, you take a shower, you get dressed, and you need a nap before you can go to work, right? So it has to be taken at bedtime. It can be sedating, and I don't know why, but I cannot tell you how many times patients have come into me, and the problem with their hormonal therapy is that, they were taking their progesterone in the morning and just feeling draggy all day, tired all day long. Now, Premarin, at Wyeth, in an effort to stay in business, or Premarin, I guess, was taken over by, I think, Upjohn or one of the other pharmaceutical companies. They did come out with a different way of protecting. The only reason you need progesterone is to protect the uterine, the endometrial lining from estrogen's effect. The way a normal menstrual period works is that estrogen causes growth of the endometrial lining, and then progesterone causes maturation. And in the absence of a pregnancy, that maturation causes the cell lining to shed every month. That's a normal menstrual period. But if you have a uterus and now you're taking estrogen for your vasomotor symptoms, your other menopause-induced symptoms, you don't take progesterone, then you have the stimulation of growth without maturation. Growth without maturation can lead to an endometrial cancer. So you have to give some kind of progesterone to thin the endometrial lining. Or this new thing is a selective estrogen receptor modulator, which will have both agonist and antagonist, pro and against forces. But benzodiazepine has been combined with estrogen, and it has been shown to protect the endometrium. And so you have this tissue-selective estrogen complex, no progesterone, that will protect the uterus, but it is still that equine-derived estrogen, which has pros and cons, and I can talk about that too. These zebras, they're scratching themselves. I have a video of this where they're like, they are so into this rock. They were having the best time. All right. So the whole point of this slide is to tell you that there are lots of preparations available on the commercial market for hormone replacement. And most all of them are now starting at a lower dose than the 0.625 of Premarin and 2.5 of medroxyprogesterone that was used in the Women's Health Initiative. And I'm a big fan of the lower doses, and I'm a big fan of transdermal. And I think that's my next slide. Transdermal has many benefits. First of all, you do not have first pass through the liver. Any pill you take orally is partially detoxified through your liver. And that, in the case of estrogen, induces things like triglyceride elevation, and it also induces the clotting enzymes. And that's why you saw those pulmonary emboloms and deep vein thrombosis, which increases, your risk of that increases with just age. And now if you add estrogen with that first pass through the liver, you're going to also increase that risk. So if you want to bypass that risk of blood clots, give it transdermally. You can give a tenth of the dose because you don't have that breakdown in the liver. You avoid what we call that first pass effect that induces the clotting enzymes and the impact on triglycerides. And the estrogen in the patches are bioidentical, which is not a scientific term. It's a marketing term, but it is exactly the same thing that your own ovaries made prior to menopause. The other problem with first pass through the liver is that it impacts the gallbladder. Similarly to pregnancy, if you don't have a gallbladder, it's not an issue. But if you're prone to gallstones, it's another reason to go with transdermal use. So, no increase in deep vein thrombosis. There are fewer combination choices. Some women do have irritation from the adhesive that's in the patch. And the cost was an issue previously, but now that these have all become generic patches, generic patches are less than $25 a month out of pocket if you pay full freight. That's not even a copay. So, sorry, didn't mean to. This bird was so funny. You see its little knees or bent forward. If you guys have ever thought about going to Africa for a safari, it's like the most incredible experience. It was wonderful. So the therapeutic goal should be, and this is right out of the North American Menopause Society position statement, therapeutic goal should be to use the most appropriate, often the lowest dose that's effective, consistent with the treatment goals. And the appropriate dose of progesterone is added to provide endometrial protection if a woman has a uterus, unless conjugated equine estrogens are combined with benzodoxifene, the selective estrogen receptor modulator we've already talked about. But otherwise, you don't need a progestin. And I know that some doctors have said, okay, estrogen might be associated with breast cancer, though the estrogen alone was not. It was only seen with medroxyprogesterone acetate. It was probably the MPA that was a culprit, but some physicians have then prescribed massive doses of progesterone to try, which there's some overlap, it will help, but it's not as effective, and there's really no indication for it alone. So I'm going to talk about bioidentical. As I said, a marketing term. It implies that the hormone has the same chemical structure as endogenous hormones, which is available commercially. You do not have to get it compounded. However, bioidentical is mistakenly perceived as only available from compounding pharmacies by a third of physicians, not just patients, but by physicians. And that is a mistake. It is available through commercial products. And I'm going to talk about why that's a good idea. So compounded medications were initially intended as a patient-specific prescription for unique indications. All right, the micronized progesterone that's on the market that is available by prescription is in peanut oil. So if you have somebody who has a peanut allergy, they may not be able to take that medication, and it's perfectly appropriate to go to a compounding pharmacy and say, compound this in a different vehicle. I understand that. I don't have a problem with that. Compounding can be used to make mango flavored lollipops for the child's chemotherapy, or your dog's medication is compounded in a liver flavor or something. Those are appropriate indications for compounding pharmacies, but that's no longer the case. All the protections that dictated that this is what compounding medicine should be have been lobbied out and removed, and now they are commercially manufactured across multiple states, not for a specific patient. Compounded hormonal therapy, CHT, can contain estradiol and estriol, which is that postmenopausal estrogen, which is sometimes referred to as bias. It can contain estrone, which is, estriol is the pregnancy estrogen, which is called bias, with estrone, which they typically call trias. It may have progesterone in variable amounts. It may have androgens, specifically testosterone or some of the testosterone precursors. It can vary a great deal. Interesting compounding medication preceded the Women's Health Initiative. There were a couple of other studies that showed a negative impact of medroxyprogesterone acetate, specifically on lipids. And so micronized progesterone was of interest to OBGYNs, and many were prescribing micronized progesterone, which could only be obtained from compounding pharmacies prior to 2000 or so-ish. In 2013, there's maybe 100 internet sites that were talking about the safety of compounded hormones, including less breast cancer risk. Not true, though maybe micronized progesterone has some benefits over medroxyprogesterone acetate. Certainly, this was overstated. There's probably there are probably multiple millions of women who are using compounded hormonal therapy, and this study was from 2015. The volume now of women using compounded hormonal therapy exceeds FDA-approved hormonal therapy, though no publicly accessible sales and distribution data exists. And where the money goes from compounding pharmacies is untraceable. But what we do, it does seem that a lot of this is very shady. Anyway, 2016 pharmacy survey showed that this is a multi-billion-dollar industry. And that was in 2016. So this data is almost 10 years old. It is not FDA approved. For a drug to be FDA approved, you have to have clinical trials. You have to have efficacy data, which for hormonal therapy is 3 months of data. And you have to have a year of safety data. It has to be reviewed. It has to be approved. Manufacturing, labeling, adverse events, all are federally regulated. That's what it means to be an FDA-approved medication. Compounded hormonal therapy, you have formulation, compounded. There is some regulation, but it's all sort of self-regulation, which means no regulation. Labeling, added adverse event reporting was added in 2013, but it is not federally regulated. It's state regulated with highly variable compliance, which means virtually no compliance. So you have this regulatory double standard, and ironically, studies show women are drawn to compounded hormonal therapy because of a distrust of conventional hormonal therapy. Because of the WHI, they perceive compounded hormonal therapy as more natural, for which there is no evidence. Non-uniform dosing is common. The use of saliva testing to personalize compounded hormonal therapy is a moneymaker. It is not been shown to be reliable in any sense of the word. I mean, really, would we be like, drawing blood from kids if saliva testing was reliable? There's a potential for contamination and impurities because there's no regulation of transportation or storage. There's no package insert, though some of the package inserts are a problem. But you're getting my message, right? I'm not a fan of compounded hormonal therapy. The most common indication for compounded hormonal therapy, probably neck and neck with GLP-1s, right? The weight loss medications are hormonal therapy. And many women assume that compounded hormonal therapy is FDA approved, up to, 50% of women in studies, and it is not. State pharmacy boards were charged with the small volume of compounded medications when a compounding prescription was written for an individual patient, but that of course is no longer the case. Those attempts to regulate were kind of all overturned. However, they were reinstituted after we had this episode with intrathecal steroids causing 75 cases of meningitis in 20 states and 64 deaths. Do you remember when that happened? It was just a few years ago. It made all the national news. So they reinstituted 503A and 503B. However, these are all voluntary, which means it doesn't happen. And nobody's really looking behind the curtain of the compounded hormonal therapy market. Studies, what few studies have been done show that there's often over and under potency. The labeling is not accurate. More Magazine did a study in 2013 where it was just 12 prescriptions filled in various states with capsules and as much as a 2.5-fold increase in estrogen, 80% of the stated progesterone. And remember, progesterone is necessary to protect the uterus from endometrial cancer. And we have seen an increase in endometrial cancer at the same time that compounded hormonal therapy has gained in popularity. All right. So I think I've probably rattled on long enough about this, but I just want to say that I understand that there's a general dissatisfaction and suspicion of conventional medicine and the reliance on pharmaceuticals. And there's a lack of personal attention in medical care. And these things are pushing women towards compounded hormonal therapy. But and there's also a lack of precise testing. I mean, you do not see a complementary and alternative market for strep throat, right? Somebody comes in, they can't swallow their own spit because they've got a sore throat that's so bad, the worst throat of their entire life. And you take a peek in there and you see what's going on, pus on the tonsils. We can treat that. You're going to be better in 24 to 48 hours with your prescription of amoxicillin, or if you're allergic, some first-line alternative. But you don't have a complementary and alternative market because they're really good at treating that. We don't have that kind of precise testing for menopause. It's not like other endocrine disorders like your thyroid. We can measure your thyroid and adjust your thyroid hormone. Diabetes, we can measure your insulin or measure your blood sugar and adjust your insulin. This doesn't exist. The only way to adjust hormonal therapy is to talk to patients and find out how they're doing. And so this lack of precise testing, I think, also is a push towards for compounded hormonal therapy. People say, oh, but they are tailoring it just for me because I've done my saliva test at 100 or 125 a pop. So it's perceived as being safe and perceived as being customized, and there is more personal care and attention, but I don't think that that's an accurate perception. Now, the idea of natural, as I say, there are commercially available FDA-approved medications which are the same as what your ovaries made prior to menopause. And I would encourage you to explore those options. When patients say, I want to do what's natural, what is natural for us as women is to be dead by 50 years of age. I mean, the fact that we spend a third of our life postmenopausal is new. It is entirely new. Average age for women up into the 1900s, so right before the Industrial Revolution, was 50 years of age. So the other thing about natural is nobody has a problem using deodorant. Nobody has a problem using toothpaste. These things are, tooth decay, body odor. These are natural things. Nobody wants that. Nobody's riding their horse to the doctor's visit, at least in my practice. Everybody drove their car. So this concept of what's natural is a problem, but it has been exploited by the compounded hormonal market. And just a passing word to pellets, there are many women who are being lured in to using pellets, being again told these are safer, this is more natural. It is all compounded in the United States. There are no FDA-approved pellets. They often contain large amounts of testosterone.
What are pellets?
It's like a subcutaneous implant that goes in. Sometimes it goes into the abdomen and it contains hormones. And if you go to a compounded pharmacy, they will talk to you eventually about pellets and oh, you only have to do this 3 or 4 times a year. But I will tell you that lots of side effects, lots of problems. I do not advocate pellet use. Yeah, it will be no. Okay, so what are the FDA indications for hormonal therapy? I learned this on my safari. These are the female ostriches because they're brown, and then the black ones are the male ostriches. And look at all those feathers. You can see why. Okay, anyway. They're always solitary, too. When you see them out in the bush, they're always solitary. But I thought they were really interesting. So, FDA indications for hormonal therapy. There are 4. Hormonal therapy is FDA approved for moderate to severe vasomotor symptoms. Okay, the one of the most bothersome symptoms of menopause. The prevention, but not the treatment of osteoporosis in postmenopausal women. The treatment of hypoestrogenism. So this is talking about ovaries that have been removed by surgery, or if somebody is in one of these familial clusters or spontaneously of having menopause before the age of 40, and it does happen. That those women need their hormones, because remember that all-cause mortality, it goes way up for these women if they don't have hormonal therapy to the average age of menopause. It's for the treatment to moderate to severe vulvovaginal symptoms. So this is usually only local estrogen. You do not need systemic levels of estrogen to treat local symptoms that are just confined to the vagina. All right, vasomotor symptoms. They are associated with diminished sleep quality, irritability, difficulty concentrating. It's not just being hot and sweaty. The poor health status overall. There is an important relationship between changes in vasomotor symptoms and changes in quality of life and sleep that have societal and economic effects. And initially, it was felt to just be a nuisance. Vasomotor symptoms now appear to be linked to cardiovascular, bone, and cognitive risks. And women with vasomotor symptoms are have less favorable markers of cardiovascular health. Very few women do not have vasomotor symptoms. It's only about 5% of the population. So the hot flash can affect the final menstrual period in about a quarter or 15% to a quarter of women. Up to 85% of American women experience hot flashes and flushes. Thanks to the SWAN study, we know that this experience may be different in Oriental women. And this number may be a little higher in African Americans. The average duration of hot flashing is somewhere around 7.5 years. And then it goes away, and nobody really knows why, though the mechanism for how a hot flash occurs has been worked out. About a quarter of women flash greater than 5 years, and 15% flash lifelong. Sorry about that. I'm in that category, so yeah. Though it does tend to get better, it still is a problem. Flashes can be associated with palpitations and insomnia, and 70% of women are currently forgoing treatment for fear and misinformation. And I think that's really a shame. The Women's Health Initiative went on for 8 years. We had 8 years of data. Hot flashes tend to last about 7.5 years. Most women can use hormonal therapy safely for 10 years or less and not really incur risk. All right. Recurrent transient episodes of flushing, perspiration, intense warmth. I don't have to tell you guys, you know what a hot flash it is. Often ending in profuse sweating and chills. Some women only get the chills. There's a significant associated with being overweight. Now, you would think that the adipose tissue is where that postmenopausal estrone is made, that postmenopausal estrogen. So you'd think if you're overweight, you're making more estrogen, you'd be in good shape. But the insulating effect of that adipose seems to trump that little bit of extra estrogen. So being overweight tends to make that worse. That is a modifiable risk factor. I mean, if you can lose weight, maybe your hot flashes will get a little better. If you have a history of postpartum depression, of bad PMS, chances are your hot flashes are going to be somewhat worse, and it's going to exacerbate those affective disorders. There are also triggers such as alcohol. Every time I have a drink, I know I'm going to have a hot flash, and carbohydrate loading. So you can't treat it with ice cream or alcohol, unfortunately. Hormone therapy is the most effective treatment for hot flashes. During the menopause transition, women with hot flashes are likely to report reduced sleep. It seems to not just be that they're having flushes at night. It has to do with arousal and just not getting into that deeper state of sleep. It affects the entire sleep cycle. Micronized progesterone can be sedating, and if you prescribe it at bedtime, women will thank you for helping with their sleep issues. But giving these huge amounts of progesterone at night just makes people feel hungover during the day, and synthetic progestins have no benefit. This is so interesting. The hippo pool, you're sitting there and there's like 50, 100 hippos all, and you're hearing this noise, this pop, pop, pop noise, and you realize they're all farting. It's so interesting. All right. There is a new non-hormonal treatment for hot flashes. Speaking of which, you may have seen it advertised during the Super Bowl last year. I saw advertisements for F.A.C.O.G. It was once they discovered the pathway, the mechanism for hot flashes, which involved the candy neuron, and this is called candy because the work was done in Hershey, Pennsylvania. So that's why it's called the candy neuron. Anyway, so this medication, the F.A.C.O.G, I think is how you pronounce it. It's FDA approved. It will block the hypertrophied candy neuron, and so it decreases VMS by blocking the candy neuron. That's how it works. There is a black box warning, however. That's the most severe warning that the FDA can give, that you must check the liver enzymes periodically. It's metabolized through the liver, and some women just don't seem to have the right enzymes to break this medication down effectively, and you have to be willing to, go in. I think you have to check it at 2 weeks and 3 months, and then you can just do it annually. Sort of like the statins. There are just some people who cannot tolerate it, but you have to. But if your liver's good to go, this medication is a very effective non-hormonal alternative for hot flashes, which is a big thank you for the women who are thrown into menopause by their chemotherapy. So it's nice to have that in our armamentarium. Okay, let's talk about the second indication for hormonal therapy is prevention of osteoporosis in postmenopausal women. Your skeleton is a living organism, and it undergoes constant turnover. So the skeleton's a living organism. It undergoes constant turnover. You will replace your entire skeleton 3 or 4 times over the course of your life. And I don't think most of us realize that the bones are living. Everyone loses bone density with age. You don't even achieve peak bone density until you're about 30. That's why little kids can just step off the sidewalk wrong and break a bone. They don't break them more often because they have good flexibility. Their bones are springy, much springier than ours, but you don't get peak bone density till you're in your 30s. And then you start to lose, almost as soon as you get to peak bone density, you start to lose about 0.5% or 1% per year. At menopause, without any intervention, bone loss increases to 3 to 5% per year for 5 to 8 years. So if you're on the high end of this and you're losing 5% of your bone per year for 8 years, that's 40% of your bone mass just out the door. And if you didn't do a very good job of achieving peak bone density, you didn't get enough calcium, you're not physically active, particularly. I will say being overweight is the one thing that the one thing being overweight is good for is that it does help your bone density because it's work to carry all that extra weight around. But that's not the only thing it's good for. All right. There are other risk factors for osteoporosis, things like smoking, a lack of physical activity, low D and calcium intake, thyroid, parathyroid, and renal disease because of how calcium is metabolized. And then, of course, menopause, and then being underweight. This is one thing that thin people don't have that work of carrying around that heavier muscle mass. Men have heavier muscle masses than women because of testosterone. So they don't tend to have as many problems with bone density either. So conventional X-ray is not adequate. You either need a DEXA bone scan or the quantitative CT that measures the bone density. So, and of course, DEXA has become sort of the gold standard. Anyway, so, but just a whiff of estrogen will keep your bones together. 50% of women age 75 or over will have experienced vertebral fractures. 25% will develop hip fractures by the age of 80. compromised bone strength. It predisposes to increased fracture risk, and the leading factor for it is the leading factor for loss of independent living. And of course, osteoporosis can have consequences of disability and even death. This is a Cori buster. It's the largest flighted land bird, right? It still can fly, but it prefers to walk, and sometimes will walk like miles a day. But I liked it because we share a name, right? Though it's spelled with a K. It's an old German name. Tanzania had been a German protectorate at one time. All right. Hormone therapy prevents bone loss in healthy postmenopausal women with a dose-related effect on bone density. That's a level 1, meaning the best scientific evidence supports this. It reduces fracture risk in healthy postmenopausal women. Discontinuing hormonal therapy results in that rapid bone loss. So, like if you take hormone therapy for 10 years and then stop it, it's good to know what your bone density is, because that rapid bone loss is going to start up again. It's not like if you take hormones for 10 years, then you've bypassed it. It's going to start as soon as you withdraw the estrogen. Hormone therapy is FDA approved for prevention, but not for treatment. Now, another finding of the Women's Health Initiative that got no publicity in this country, though a little bit in Canada, is that women and other studies besides the WHI have shown that using estrogen will decrease joint pain and stiffness. And I know this is true because when we use hormonal blockade in women with breast cancer, one of the big reasons for not being able to tolerate the aromatase inhibitors is that they say overnight, I feel like an old woman. I'm stiff. I can't, my joints all hurt. I can't get up out of the chair. And so the reverse is also true. And I don't know why this gets no publicity, but it does help with bone pain. There's a need for further understanding of estrogen's potential effect on joint health. All right. And that's right out of the position statement of the Menopause Society. Right. The number 3 indication is hypoestrogenism caused by things like having the chemo, radiation, or surgery. Most, up to 2 million women a year go through menopause. The vast majority of those are spontaneous. Some are premature, which now has a different name. It's not called premature ovarian. When you don't know how to treat something, sometimes they just change the name. So they don't call it failure anymore. Oh yeah, it's called primary ovarian insufficiency. I did put it in the slide. Anyway, but that's less than 1% of women who become menopausal. The definition is younger than age 40, more than 2 standard deviations from that 51.7 years. And it's this group where you have an indication. If you withhold hormonal therapy from this group, there is very good studies that show that you've increased the risk of cardiovascular disease and all-cause mortality. And women need their hormones at least until the average age of menopause. It affects very few of you, but this is the point that I make to the residents, bang them over the head with this. Do not withhold estrogen from young women. Even women who have had oophorectomy because of BRCA gene, what's driving that train is a genetic risk. For you have damaged repair genes, so you're much more susceptible to breast and ovarian cancer. What's driving that train is not the estrogen, it is that genetic defect. And if you withhold estrogen from those women after you perform a oophorectomy to prevent them from having ovarian cancer, you're increasing their all-cause mortality. So just it all hooks up and works together, and I really try to make that point pretty forcefully. Women's primary ovarian insufficiency and premature or early menopause may be increased risk for. These are all the things that happen if you withhold estrogen. Okay, fracture, cardiovascular disease, heart failure, diabetes, overall mortality, persistent vasomotor system, loss of fertility. Well, loss of fertility, of course, they don't have ovaries. Bone loss, genital urinary symptoms, sexual dysfunction, cognitive and mood changes, increased risk of dementia, open-angle diploma, depression, and poor quality of life. So this is if you withhold estrogen from young women, and I think some of these same things happen when you withhold estrogen from women in their 50s. So urogenital changes. This is one of the symptoms that occurs late and worsens with age, right? This is not going to get better over time. Lots of treatment options. The epithelium, the skin of around the vagina is becoming pale, thin, less elastic, and dry. Vaginal pH increases with the loss of collagen and fat. which is what helps to inhibit vaginitis. But dryness, irritation, painful intercourse, and sometimes discharge can occur. If you treat somebody's dry, unhappy vagina, unelastic vagina, and you increase the moisture, sometimes the moisture is increased before the elasticity. You have to warn women they may see yeast infections recurring for the first time. So as long as you tell them and give them some diflucan or some over-the-counter Monistat or something, they'll be perfectly happy. But if you don't warn them, they get pretty hacked that all of a sudden they've got yeast infections, and that will go away. I mean, it's a transient effect of the increased moisture, but it can be pretty annoying. So there are non-estrogen prescription approved therapy to improve vulvovaginal atrophy in postmenopausal women. There's an intravaginal pill called, which is an estrogen precursor, and there's also one of these selective estrogen receptor modulator. I don't prescribe a lot of it. Ospemifene, which is an oral pill. And these things can also, they also act on these estrogen receptors to improve health. But there is no real contraindication for local estrogen. In one of the slides, we'll talk about that. This is more about diagnosis. That's not that important. The picture of the giraffe is kind of cool. It's just sitting down. Like, I'm tired of standing up. It was like, I thought that was interesting. There are these over-the-counter things. Replens is the only approved moisturizer. Moisturizers are intended for daily use. They're not intended for just episodic when you're having intercourse. And then you have all these lubricants, and they're mostly used to treat, they're silicone-based, and they're used to treat episodic dryness or just when you want to have intercourse. It's shorter acting. It may need repeated application. The water often, sometimes they're flavored or they're scents that are used for pleasure. Patients can individualize. There is some oil-based ones that are a little better than water and silicone, but you have to be aware of whether if it's olive oil or coconut that may be attractive to your pets. On your sheets and stuff. I mean, not you personally being silicone can last longer, though it can be very tacky when it dries. If you're trying to avoid hormonal therapy, you can also get prescription viscous lidocaine. That's that gel that's numbing, and it can act also as a lubricant. But there are all these treatments out there. The main thing is that you shouldn't suffer vaginal dryness. There are all kinds of treatment options out there. They're all effective. They're all similarly effective. It can take a while to see improvement because they're so low dose. You have to be prepared for the possibility of a yeast infection. Progesterone is not needed, even if you have a uterus. Endometrial surveillance is not needed. The amount of estrogen that's needed to make the vagina feel functional is so small that we don't have to worry about endometrial cancer. Abnormal bleeding requires a workup, whether or not, I mean, you can't just write it off to that little bit of estrogen that you're giving vaginally. It has to be explored. The main thing I want to tell you is that there is a black box warning for all estrogen products in the United States because of the Women's Health Initiative. And it's going to say that you can get blood clots and stroke and cancer. And it's the same whether you're taking oral or transdermal or even tiny little amounts of vaginal. And there's no scientific basis for it. And it's the menopause societies, American College of OBGYNs have been lobbying for years to change the black box warning that's on the local estrogen therapies. And I just want to tell you that if you see that black box warning on a local estrogen therapy product, it really doesn't apply. I have to tell my patients this all the time. I'm not. I also want to say I'm not doing menopausal medicine anymore. I work at the College of Medicine teaching medical students now. I've closed my menopause center. I was very sorry not to be able to find somebody to take it over. All right, duration of use. For women with genitourinary symptoms of menopause, vaginal dryness, low-dose vaginal estrogen therapy can be considered for use at any age and for an extended duration. This is straight out of the hormone therapy position statement of the North American Menopause Society. And I don't know why people are fearful of prescribing it. I think it really can help people, and there's just no correlation with the risks for systemic hormonal therapy. Systemic therapy does not generally improve sexual function, sexual interest, arousal, or orgasmic response, independent of its effect on genital urinary symptoms of menopause. If it hurts every time your partner wants to have sex with you, pretty soon you don't have much libido. But if you can fix the fact that it hurts, then libido and all that stuff comes back. But it doesn't have like an independent, like if you take hormones, then all of a sudden you're going to like this partner that doesn't do housework, isn't very supportive, and has all kinds of other problems, right? Okay. So it doesn't fix people's sex life, except if it's because it hurts. And then it works really well. All right. So I think most of the other points we've already made. All right, this cat's cool. All right. All right. So some additional consideration. It is beneficial effects on the skin. It makes the skin more elastic and thick, not just in the vagina, but everywhere on the body. It helps the hair and the male pattern hair loss. It counteracts that. Hormonal therapy decreases the risk of macular, age-related macular degeneration. It open angle glaucoma, but that's not the common glaucoma that people have. Common glaucoma is closed angle, but it does counteract open angle glaucoma. It can have some beneficial effect on cataract, but there's so many other things that cause cataract. I don't think it's a really significant impact. It doesn't have any impact on smell. In small trials, it may help with vertigo or balance issues, which is a big problem with aging. It can increase the risk of gallstones if taken orally. Less so with transdermal, which we've already talked about. Again, this is more like what I beat over the head of the residents with. It does seem to have to stave off type 2 diabetes. It's not government approved for that indication. Weight loss, diet, exercise. Sorry, that old, those are still ways to treat that. But hormones certainly can help. It's not contraindicated if you have diabetes. Many women are fearful of hormonal therapy because they think they're going to gain weight. The menopause transition is associated with an increase in body fat and a decrease in lean body mass, but this has a lot to do with people not being active. It really, if you stay physically active, you can counteract these effects of just aging. And although hormonal therapy may help attenuate abdominal adipose accumulation and weight gain associated with menopause transition, the effect is small. But if it has any effect, it's a beneficial effect. It's the hormones are not what's driving the weight gain train. It is not recommended at any age to prevent or treat a decline in cognitive function or dementia. Once it is established, it may exacerbate it. But the effect of hormonal therapy at baseline, if you take it prior to having any age-related cognitive changes, it can stave it off, and it may have a very beneficial effect. So if you initiate it immediately after menopause, and especially after bilateral, having the ovaries removed surgically, it may affect cognitive function beneficially. So that's this critical window hypothesis that in Alzheimer's prevention, you may see as much as a 50% decrease if using hormonal therapy perimenopausally. I'm going to go back and talk a little bit more about mood and memory here. Many women find the perimenopausal transition to be a big upheaval in their life, but postmenopausally women report that they feel happier and more fulfilled than any other time in their life. So perimenopausally, that's when we see the mood swings, irritability, and fatigue. And the SWAN data gave us the scientific underpinnings for this. I have to tell you that prior to women investigating menopause, it was all poo-pooed as like in their heads, right? By the established medical community. So we do need diversity in medicine. Short-term memory and cognitive and concentration improves with estrogen replacement when it's started in menopause. And women with we already talked about that. If you're vulnerable to affective disorders, it's going to be exacerbated by the perimenopausal transition, and that's reason enough, I think, to prescribe hormonal therapy. It is not, however, government approved to treat mood disorders. There is some evidence that estrogen therapy has antidepressive effects similar to that from antidepressant agents. So I do think if I have patients who have struggled lifelong with depression, I do encourage them to use hormonal therapy if they're having symptoms of menopause. So even in non-depressed women, estrogen therapy can enhance mood and improve well-being. All right, Heart Smart. I think I can just summarize this by saying estrogen is good for the heart, but not Provera, not the progestin. It was seen as protective. I'm not going to belabor this point. I just want to show that the leading cause of death for women is heart disease. It outstrips, this is all causes of cancer, not just breast cancer. Stroke, chronic obstructive pulmonary disease, and pneumonia, influenza. The magnitude of the impact of cardiovascular disease on you as women is staggering, and you should know what your triglyceride, your HDL, your blood pressure, your fasting blood sugar, you should know what those numbers are and do what it takes to get those numbers in good working order, because cardiovascular disease is an issue. It's not hormonal therapy is not government approved for primary or secondary cardio protection, but it is beneficial to the heart. Now, breast cancer. The risk of breast cancer related to hormone therapy is low, with estimates indicating a rare occurrence, which we've talked about those numbers, less than one additional case per 1,000 women per year of hormone therapy use, or 3 additional cases per 1,000 women when used for 5 years with conjugated equine estrogen plus medroxyprogesterone acetate. This is the WHI study. The data for natural progesterone is much better. Women should be counseled to the risk of breast cancer, but the risk of death from breast cancer is unchanged by 10 years of hormonal therapy in the perimenopausal period. You may be a little more vulnerable to getting it, but women who are on hormonal therapy at the time that breast cancer is diagnosed tends to have earlier disease, earlier stage, more easily treated. Not that I recommend that people take hormonal therapy so it's easier to treat their breast cancer, but that 1 in 8 statistic, we are all fearful of breast cancer. But 1 in 8 is 1 in 8 90-year-old women that didn't die from cardiovascular disease or cancer or, the bus hitting them or anything else. You have to live to be 90 for that 1 in 8 statistic to mean something. And then at that point, your risk of dying from anything has become very high, right? If you're 90 years old, it's 1 in 2 for 1 in 2 for heart disease, 1 in 2 for developing Alzheimer's. I mean, the numbers go way up. So, different hormonal therapy regimes. This is from a French study that showed that the natural progesterone brought that risk, instead of being elevated, as we saw in the WHI data, it brought it down to what we saw to 1, meaning no change in risk, which is what we saw in the Premarin-only arm. Actually, in the Premarin-only arm, we saw a decrease because some people think that equine estrogens have some of the selective estrogen receptor modulator effects and have some anti-estrogen effects on the breast. But that's getting into the weeds. We don't know whether these newer therapies are going to be beneficial, but they probably are. It does not further increase the risk of breast cancer in women at high risk because of the BRCA gene. There's no additive effect of breast cancer from hormone therapy use, other than what we all have as aging and other risk factors like being overweight and sedentary, other modifiable. It is, however, not recommended for survivors of breast cancer. And regular breast cancer surveillance is, of course, recommended to everybody, all postmenopausal women. Endometrial cancer is not caused by hormonal therapy. It's caused by either unopposed estrogen or just aging, and should be treated and can be treated. And ovarian cancer, use of oral contraceptives decrease the risk. Using hormone replacement may have some small increase in risk, but we're not really recommending that you stay on hormonal therapy lifelong. But it's a small risk. Colorectal cancer, decreased risk, well documented. Duration of use, it does not need to be routinely discontinued in women aged 60 to 65 years of age. It needs to be discussed. Every 5 years that I saw women, I would try to reduce their dose. Many women could come off hormonal therapy after 10 years of use. Some women know. Remember that 15% they're going to have lifelong symptoms. It's amazing to me that the brain adjusts to the lack of hormones. All right, this is the end. Get it? And I'm going to stop here. And if there are any questions, thank you.
Oh, freedom.